Estamos grabando.
Bienvenidos a esta nueva versión del Webinario Internacional de Educación Continua en Vía Aérea, organizado por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales de la Facultad de Medicina. Esta es nuestra versión 2023 y nos enorgullece que hoy día completamos nuestro 26º webinario ininterrumpido mensual para todos ustedes. El webinario es organizado, como les decía, por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales, que es dirigido por el doctor Ricardo Latropa Allende. Este programa tiene por objeto lograr un especialista capaz de ejercer la anestesiología en forma integral, entregando al paciente una atención acorde con la evolución de la especialidad, adaptándose a los cambios epidemiológicos y al desarrollo de la tecnología. Nuestra decana, la doctora Patricia Muñoz Casas del Valle, y nuestro director de la Escuela de Posgrado, el doctor Antonio Eblen, son la base que nos da el sustento universitario a esta actividad. También esta actividad está apoyada por la Sociedad Europea de Vía Aérea, la EAMS, y también la Sociedad Española de Anestesiología y Reanimación. Este año tenemos una constelación de expertos de todas partes del mundo, muchos de ellos también latinoamericanos, provenientes de diversos países, de Nueva Zelanda, Argentina, Venezuela, Brasil, Colombia, España, Bolivia, Estados Unidos, Turquía. Y en esta oportunidad tenemos un representante y un gran experto proveniente del Reino Unido. Les recuerdo que este webinario también les ofrece certificación de su asistencia, para lo cual deben inscribirse en un formulario que se les ha enviado o se les va a enviar de manera permanente en cada sesión. Contamos también con traducción simultánea de la empresa Traducciones Remotas, que traducen las conferencias al portugués, al inglés y al español. Los invitamos a participar a todos activamente, ya sea levantando la mano. Hay un botón abajo en su pantalla donde dice reacciones, y ustedes pueden accionar y levantar la mano para pedir la palabra libremente después de terminada la conferencia. También pueden hacernos llegar sus comentarios y preguntas a través del chat. Nos encanta saber de dónde nos están viendo. Saludos desde todas partes de Latinoamérica y del mundo, y estamos felices de poder conectarnos con ustedes. Este webinario muy especial cuenta con la participación del doctor Imran Ahmad, quien es anestesiólogo consultor en el Guías and St. Thomas Found Trust de Londres, Reino Unido, donde es director clínico adjunto para anestesia y medicina perioperatoria. También es profesor clínico honorario en el King's College de Londres. El doctor Ahmad tiene un interés especial en el manejo de la vía aérea difícil y es el director del curso de manejo de vía aérea en su hospital, y ha sido líder del programa avanzado de vía aérea durante más de 10 años, entrenando a un sinnúmero de residentes durante ese tiempo. Es presidente de la Difficult Airway Society del Reino Unido, habiendo sido secretario honorario durante los 3 años anteriores y miembro del comité de la DAS por más de 11 años. Tiene una extensa actividad de investigación con cerca de 3.000 citas y 100 publicaciones realizadas por pares que incluyen 3 guías DAS, guías de intubación DAS de 2015 y 2020, las guías de intubación vigil y de manejo del hematoma post-tiroidectomía, y actualmente preside las guías de intubación y extubación de la DAS. También ha sido autor colaborador del libro Principios del manejo de la vía aérea, editado por la doctora Hackberg y Benumov. En 2020 recibió el premio Anesthesia Journal Paper por el estudio Intubate COVID. Como resultado de su extenso trabajo académico y clínico, es invitado regularmente a hablar en congresos nacionales e internacionales. Esto le ha permitido viajar alrededor del mundo, y dice que actualmente espera una invitación para hablar en la Antártida. Estimado Ahmad, quizás se produzca teniendo Chile un territorio antártico soberano. Te esperaremos, totalmente. El año pasado participó en una serie de proyectos innovadores preseleccionados para la final de los premios nacionales British Medical Journal Awards 2021 y Nursing Times Awards 2021 por su trabajo en el desarrollo de las estrategias HIT para ayudar a reducir el retraso quirúrgico y mejorar la eficiencia de los quirófanos. También dirige muchos cursos internacionales multidisciplinarios en varias plataformas, incluido el curso de manejo de vía aérea en su hospital, que cuenta con más de 20.000 participantes registrados. Para nosotros es un gran privilegio contar con el profesor Ahmad en un tema muy central en el manejo de la vía aérea, siendo él el líder en el trabajo que llevó a la formulación de las guías para la intubación vigil. Bienvenido, doctor Ahmad. Es un honor tenerlo en esta oportunidad en nuestro webinario. Antes de iniciar su charla, invito a los participantes a responder un par de preguntas que van a ser brevemente comentadas por el doctor Ahmad en cuanto a sus respuestas, como modo de introducción al tema. Las preguntas. Pregunta número 1. ¿Alguna vez ha evitado hacer una intubación vigil estando indicado, prefiriendo una técnica con paciente dormido? Los invito a responder. Si alguna vez ha evitado hacer una intubación vigil, si no la ha hecho, estando indicada, prefiriendo una técnica con paciente dormido. Aproximadamente la mitad de los participantes están respondiendo que sí o que no. Los que responden que no es que han hecho la intubación, nunca lo han evitado, nunca han preferido una técnica de un paciente dormido. Perfecto, parece que ya está respondido la gran mayoría, ¿sí? Ya, vamos a los resultados. Ahí están los resultados. Imran, ¿algún comentario? La mitad de las personas han evitado y las otras no lo han evitado. ¿Qué te parece?
That's very interesting. What that tells me is that either half of the audience who have never avoided doing an awake intubation when indicated, it means that they are confident in doing awake intubations and they're very happy to do them when indicated. It also tells me the other half have avoided doing awake intubations when indicated and done a sleep intubation instead, which means that the other half may not be as confident as doing awake intubations. So we have a split, a 50-50 split, where maybe half the audience are confident at doing awake intubations and the other half are not confident. So my job today is to convince the other half who are not confident to be more confident in doing awake intubations and do them when indicated.
Exactamente. Vamos a la segunda pregunta. Antes de iniciarlas, aquí está la segunda pregunta. Se pregunta, ¿se ha arrepentido de no haber hecho una intubación vigil cuando quizás debió haberlo hecho? Interesante pregunta. ¿Se ha arrepentido de no haberla hecho? Aquí estamos 50 y 50 aparentemente, ¿eh? ¿Estamos listos, parece? Compartirla. Oh, algo. No sé si ven los resultados.
Yeah, I see them again. Very, very interesting. So almost again 50-50. So it seems like, have you ever regretted not doing it? And so about nearly half have said yes, they have regretted not doing it, and half have said no, they haven't. So again, so what that tells me is the half that have regretted doing it probably should have done an awake intubation on that occasion, whereas the ones who said no were happy that they went for the sleep technique and then that worked for them. So for me, that's very interesting results for those two questions.
Fantástico. Entonces, doctor Ahmad, te pido que compartas tu pantalla para que iniciemos tu presentación. Les pido que silencien sus micrófonos, por favor, para que no haya interrupciones.
Good. Can you see my screen okay?
Sí.
Lovely. Okay. So shall I get started? Okay. Lovely. Well, thank you so much for inviting me. So I'm going to talk, or I've been asked to talk about awake tracheal intubations or awake intubation. Sometimes people refer to it as awake fiber optic intubation, but we decided to change the terminology to awake tracheal intubation because we felt that it reflects what you're doing more accurately, and it's an easy ATI, is very easy way to describe what you're doing. But I'm going to slightly change the topic a little bit. Oh, hang on, let me just move this way. Change the topic slightly because what I want to do is I don't want to just talk about awake tracheal intubations, but I also want to talk about why we should do awake tracheal intubations, which is partly why I asked those questions that we did. I wanted to see whether you did them when you felt you should do them, or whether you avoided doing them when you felt you should do them, and what the outcomes when you made that decision. And so part of this talk is I'm going to be talking about why we should be doing awake tracheal intubations, especially when we have video laryngoscopy and better technology available to us. And then the other part of the talk, I will talk about how you should do awake tracheal intubations and some of the evidence that we've found and the guidelines that we put together, which were published a couple of years ago. So I'll start off by talking about video laryngoscopy. Now, if you look at the current literature, there's lots and lots of papers, systematic reviews, meta-analyses, randomized controlled trials, case reports, and also guidelines that mention them, review articles, and even editorials. So lots and lots of paper, lots and lots of evidence, lots and lots of people saying that how good video laryngoscopy is. They say things like and what they have found is that it reduces the incidence of failed intubation. It increases the success rate of first attempt intubations. You get better views of the glottis, reduced rate of esophageal intubation, reduce the failure of intubation, even whether the patient is known to be difficult or predicted to be difficult. Better views of the glottis. It's beneficial for the patients, better team dynamics, better for human factors elements, and better for training. They say video laryngoscopes outperform direct laryngoscopes for intubation, and some even suggest the use of routine video laryngoscopy whenever feasible. And even if you look at the most recent Puma guidelines, they're very pro using video laryngoscopy, as well as for the undetected esophageal intubation guidelines as well. And this is a nice big Cochrane review that was published a few years ago now, where they looked at video laryngoscopy, and what they found in particular for patients with predicted difficulty, the odds ratio was in favor of video laryngoscopes. So even when you predict a patient to be difficult, a video laryngoscope it does show to be better than direct laryngoscope. But what you must remember, and this is the thing that often gets forgotten, is that these studies and even this systematic review is comparing video laryngoscopy to direct laryngoscopy. Okay, so yes, video laryngoscopy is better than direct laryngoscopy, but doesn't mean that it's better than an awake tracheal intubation. And that's the thing I want to highlight as to why we need to do awake intubations. So if you compare video laryngoscopes to direct laryngoscopes, I think the evidence is very clear and is very good. And I support this evidence, which is that video laryngoscopy is better and more beneficial than direct laryngoscopy. And if you look at the failure rate, the failure rates for direct laryngoscopy is up to 5.5%, whereas for video laryngoscopy is 2.5%. So therefore, video laryngoscopy is better. However, what you must remember is that video laryngoscopy does have a failure rate, and the failure rate actually I think is quite high. 2.5% is still quite high. And don't forget, this is an asleep patient, so you're now having an asleep patient who you failed to intubate with a video laryngoscope, who may be difficult. So you just have to bear that in mind. Yes, it's better. Yes, it has a higher success rate. Yes, it's reduces esophageal intubation, etc., but that's all compared to direct laryngoscopy. Okay, so let's see what it's like compared to awake intubation. And if you look at these patients, these are all examples of patients with difficult airways. Now, I think if you decided to put this patient to sleep, there's no doubt in my mind that the first option that should be is a video laryngoscope, because they all have elements of difficult intubation. But what about different type? What about this sort of patient? Look at
mouth
this
as
patient.
wide as you possibly can.
So this patient has a no mouth opening, has had lots of surgery, has had radiotherapy, has trismus. You can't use a video laryngoscope in this patient because even the patient is paralyzed, because it's going to be very, very difficult to intubate through the mouth. Another example of a patient who's had multiple maxillofacial surgery, free flaps, radiotherapy, edematous tissue, reduced sort of neck extension, previous tracheostomies. These are the sort of patients where, yes, a video laryngoscope is better than a direct laryngoscope, but is it better than doing an awake intubation? Because I would certainly do an awake intubation on both those patients without hesitation, and I certainly wouldn't want to put the patient to sleep and use a video laryngoscope. So the question I'm going to ask is video laryngoscopy better than doing an awake tracheal intubation? So let's look at the studies. I like to use evidence to back up whatever I say. But actually, if you look through the literature, there are 0 studies directly comparing video laryngoscopy to awake tracheal intubation. Hundreds of studies comparing video laryngoscopy to direct laryngoscopy, but not to awake intubation. So there's no evidence to suggest that one is better than the other. However, my job is going to look to try and convince you to think more seriously about doing an awake intubation when you're faced with an anticipated difficult airway. So let's look at the instance of difficult airways. And now, if you look at the literature, the overall instance of difficulty with different aspects of airway management across all patients who are having a general anesthetic are listed here. I'm not so interested in the numbers. I'm more interested in the arrows. So now, if you predict a patient to be difficult, then every aspect of airway management becomes more difficult. There's an increased complication rate, an increased failure rate, increase in everything in terms of difficulty when you anticipate the patient to be difficult. Okay. So I think, again, the evidence is quite clear. There's a higher risk of complications when you perform an asleep intubation if you predict the patient to be difficult compared to the normal group of patients. Now, what is the instance of complications and failure when you do the intubation awake? So same groups of patients anticipated and predicted to be difficult, but what is the failure rate if you choose an awake technique? So if you can see, the incidence of can't intubate, can't oxygenate reduces, the instruments of emergency front of neck airway reduces. We don't know the data on death, but that probably is reduced as well. So when you compare the arrows for an awake intubation in patients with anticipated difficult airways, the complication rates are much lower than when you compare it to putting the patient to sleep and then managing the airway asleep. The failed intubation arrow has gone up. The incidence of failed intubation is slightly higher, but that's because there are smaller numbers. You're doing smaller awake intubations, and because you're doing less numbers, if you fail, then that becomes a higher percentage. However, if you look at the outcomes of those failed patients, the outcomes are normally the patient is woken up, or that the patient is ventilated, or it's very unlikely, it's very low instance of emergency frontal neck airway or death. Whereas if the patient is predicted to be difficult and you put the patient to sleep and then you fail, you're more likely to run into trouble because that's what the data suggests. So I hope that sort of convinces you that in predicted difficult airways, there's a lower risk of complications when you perform an awake tracheal intubation compared to when you put the patient to sleep. But there's a slight problem with what I'm saying, and the problem is highlighted by this study. So this is a nice big Cochrane review of 133 studies, which looked at bedside airway assessments and the outcomes and how good we are at doing this. And actually, what the study concluded was that bedside testing has a low sensitivity and high variability, and that it doesn't appear to be a good screening test. And what does that mean? What that means is this, and this is a NAP4 study, and there's a whole chapter devoted to airway assessment. And even in that NAP4 study, what they found was that often an airway assessment wasn't done very well, or wasn't done properly. And even though when it was done, there was poor judgment, i.e. we did not necessarily act on our findings. So we assessed the airway, which is not very good anyway, because the other studies have shown that. But even when we predict the airway to be difficult, we didn't always act on it. And that's why we ran into complications, and that's why these patients were reported in the NAP4 study. So not only is it important to do a very good and thorough airway assessment, it's also important to act on it, especially with patients with head and neck pathology. And why is that the case? Well, again, let's look at the NAP4 study. Again, there was a whole chapter devoted to head and neck pathology. And if you look at the data, in total, in the NAP4 study, there were 58 emergency frontal neck airways performed in total that were reported in that 1 year study. Of the 58, 43 of them were patients who had head and neck pathology. So what that tells you is that if the patient has a difficult airway or has a head and neck pathology, then they are much more likely, if you run into trouble, to require an emergency frontal neck airway than a patient who is not from this group, who does not have head and neck pathology. So you have to really take these patients very, very seriously and really plan their airway very, very carefully, because if you run into trouble, you're much more likely to end up in a can't intubate, can't oxygenate scenario, which may end up requiring an emergency frontal neck airway. And that's why this group of patients have to be assessed very carefully. Now, you may argue that the NAP4 study is very old. It's over 10 years ago now, and it's not relevant to current practice. And that there is probably some truth in that argument. So I'm also going to quote this paper that we published last year. It's the analysis of the DAS, difficult airway database. And this is a database where across the UK, hospitals or individuals who have an airway complication report the complication onto this database, and then and there's numerous questions that are asked, and then we put this data together and we analyzed it to share the data and learn from the data. And what we found was there were nearly 640 patients in this report, and more than half of those patients, the anaesthetist assessed the airway and predicted the airway to be difficult. Okay, so it was an airway assessment was done, and they predicted the airway to be difficult in more than half of those cases. And the primary airway plan for the majority of those anaesthetists who anticipated the airway to be difficult was to put the patient to sleep and either use a direct laryngoscope, a video laryngoscope, or a supraglottic airway device. So 90% of the cases, when the anaesthetist predicted the patient to be difficult, plan A was a GA intubation with either a direct laryngoscope, a video laryngoscope, or a supraglottic airway. And then they ran into trouble, and that's why this patient was reported in a difficult airway database. So important learning here is that if you predict the airway to be difficult, then plan carefully. Don't just think, oh, I'll use a video laryngoscope and I'll successfully intubate the patient, because that's not always the case, depending on the type of difficulty that the patient is predicted to have. This is a nice study published from the Oxford group, again, last year, which is like a mini NAP4 of all the hospitals within the Oxford region. And what they found was that patients, the airway complications that occurred in patients who were predicted to be difficult, who were predicted to be easy, were actually very low. So you very rarely saw complications in patients who were predicted to be easy. But if the patient was predicted to be difficult, then you're 45 times more likely to have complications. So it's much more likely to have complications if you predict the patient to be difficult. Yet, in the majority of the cases, when they predicted the patient to be difficult, they still put the patient to sleep and use a direct laryngoscope or basic airway techniques, and didn't plan appropriately, and that's why they ran into trouble. So if you predict the patient to be difficult, then you should really plan better. And this is an example of a patient in my own hospital. So I was on one of my hospital sites purely by chance. Somebody just asked me if I wouldn't mind helping them with the case. This patient was small, only 57 kilos. She had spinal muscular atrophy. She needed an emergency laparotomy because she perforated diverticulum. And the plan was to put the patient to sleep and intubate the patient with a video laryngoscope. So when I went to assess the patient, I noticed that she had no mouth opening, no tongue protrusion, no neck extension, was on nasal CPAP, and I thought she had a very, very difficult airway. And I said, absolutely no way, we're going to do an awake intubation on this patient. So here's the patient's airway. Well, not really assessment, but here's the patient who I'm trying to suction her mouth, but I had to use a metal suction catheter because there was hardly any gap between her teeth. And I said we're going to do an awake intubation, and so this is us doing the awake intubation. It was again, we do many awake intubations in my hospital, and I do many myself, and I train others to do them, and that's why I was very confident and comfortable doing awake intubation. If we'd put this patient to sleep and managed the airway to sleep, I think we would run into some real trouble because the mouth opening was very limited, neck extension was very limited, and I think that they would have probably ended up having to do an emergency frontal neck airway. But even that would have been difficult because the patient's neck extension was so poor. Whereas here, we're doing a fairly routine, fairly straightforward, very safe awake intubation, which is stress-free for everybody. And as you can see, we managed to intubate her quite easily without too much difficulty and manage the airway safely. And that's why I feel we should do more awake intubations when indicated, and keep practicing, know how to do them well, because the more you do, the better you are. And these are other examples. In my own hospital, we're a major London teaching hospital. We have lots of airway lists. We're an airway referral center. And despite that, very difficult airways, sometimes the anaesthetist will still choose plan A as going off to sleep or a video laryngoscope, whereas I would certainly say, no, these patients should have an awake intubation. And I think that what this highlights is awake intubations are underperformed. We don't do them as often as we should. Why is that the case? Well, there's various reasons. If you look at the data, if you look at big centers across Europe and the US where they do lots and lots of awake intubations, the overall numbers of awake intubations compared to sleep intubations are very low. Even in our hospital where we do many awake intubations, it's about 1%. And if you extrapolate from NAP4 data, in the UK, only about 0.2% of intubations are done awake. So the numbers are very small. And that's one of the reasons why we don't do them, because we maybe not be confident in doing them, and we might not feel that we're going to succeed because we don't do them very often. And Adam Law from Canada published this paper earlier this year, which is great, because on this paper they looked at the number of awake intubations done in their own hospital, and what you find is that despite a 98% success rate, a very, very high success rate in patients with predicted difficult airways, despite having such a high success rate, the number of awake intubations is decreasing. And if you go back to from 2014 to now, it's about half or the number of awake intubations done in their hospital. COVID obviously contributed, but if you look overall, numbers are dropping. Why are these numbers dropping? Maybe because we have video laryngoscopy, maybe because there are other techniques available, or is it because we just don't do enough and we're scared of doing them? So because of those reasons, we decided to write some awake tracheal intubation guidelines, which I chaired, and this was published in 2019, early 2020. At the end of this talk, I'll put up the QR code again. So it's an open access paper. It's free to download, and you can, everything I'm saying to you today is in this paper as well. So I do encourage you to scan that, get a PDF of the paper, and it's open access. So it's free to have. And I'll show that QR code at the end of the talk as well. And in the paper, we compared the failure rates for a sleep versus awake intubations in patients who were predicted to be difficult and not. And this is the data I showed you earlier. And what we've shown is that in all aspects of airway management, managing a patient awake has fewer complications than managing a patient asleep, especially if they're predicted to be difficult. And therefore, it's something that must bear in mind. We also put a recipe together. We call it a recipe, but it's actually the recommended DAS awake tracheal intubation technique. And by this, what I mean is that we don't say this is what you must do. What we say is this is a recommended technique if your normal technique isn't working, or if you don't do it very often and you want some advice on how to do this. If you have a technique that works very well for you and it works and you do it all the time, then stick with that technique. But if you want some help and advice, or you don't do it very often, then this is a very nice, easy, straightforward technique. And this is something that we've all adopted, and we use this technique all the time. And we broke it down into 4 areas: topicalization, sedation, oxygenation, and performance, i.e. how you actually perform the awake intubation. So very briefly, what we've suggested is that you always give extra oxygen when you're doing an awake intubation. We recommend using high flow nasal oxygen if you have it available. It doesn't really matter what you use, but what does matter is that you start oxygen early and that you give supplemental oxygen, regardless of how you give it, because the more you give it, the better it is. So you must always consider giving extra oxygen when you're doing an awake intubation, and it doesn't matter what technique you use. The next thing we recommend is topicalizing the airway. Now, this is really important because a successful awake intubation means that you're more likely to succeed if you do a good topicalization. And what we recommend is for nasopharynx, we use cofenacaine spray, which is local anesthetic, as well as vasoconstrictor. Some people use cocaine. The problem with cocaine is it has a higher risk profile, higher complication rate, even though it's as efficacious as cofenacaine spray. Has a higher complication rate, and therefore it's much better to use cofenacaine spray because you're less likely to get the complication, which are usually cardiovascular and neurological. For the oropharynx, we recommend use 10% lidocaine spray. And using a mucosal atomizing device to deliver this. You can give up to a maximum dose of 9 milligrams per kilo, which is lots and lots of spray. Really important to get your topicalization right, because if you have good topicalization, you're much more likely to succeed with an awake intubation. And one of the areas which is a little bit controversial is sedation. And the reason why it's controversial is because if you over-sedate the patient, then you can run into real trouble. And the biggest complication rate of awake intubation is usually down to oversedation, where the patient becomes apneic, or the patient stops breathing, or becomes hypoxic. And that's why we recommend only using a single sedation device, and we tend to use remifentanil, but you can use dexmedetomidine as well. And also, if you don't do this very often, that you have someone who specifically looks after the sedation and is responsible for the sedation, so that you can look after the patient, look after the airway. Really important that you don't oversedate the patient. Really important that you don't oversedate the patient. Firstly, and secondly, you don't use sedation as a compensation for poor topicalization. So it's really important that you get your topicalization right, and you don't use sedation to overcome poor topicalization, but you use sedation purely to help make the patient comfortable and maybe give some amnesia. And then once you've got good topicalization and good sedation, and you think about your positioning of the patient, you then perform the actual procedure. And here is our setup. So we have sedation going, we have our monitors set up, we have our assistant set up, we have all our equipment set up, all in a nice position. And you spend a bit more time topicalizing the patient and preparing the patient. So you actually, when you intubate the patient, it only takes a few minutes. Everything else is takes a bit longer, but actually makes you much more ready to, somebody took one of me being intubated as well. Now, one of the things that we recommend is a 2-point check. Now, the 2-point check confirms the position of the tube before you put the patient to sleep. So the first point of the 2-point check is to visualize the carina and the tracheal rings. And as you pull back with the scope, you can then see the inside of the endotracheal tube. That's the first part. And the second part of the 2-point check is capnography. So if you can see the tracheal rings and the carina, and you can see capnography once you connect the machine to the patient, then the tube can only be in the trachea and it's correctly placed in the trachea. Then it's safe to put the patient to sleep. So we recommend that 2-point check before you anesthetize the patient and before you put the patient to sleep, because it just means that you'll know you're in the right place and that you're much more likely to it's safer to put the patient to sleep and you've secured the airway. So this is putting everything together now. So this is me doing an awake intubation in a patient in my hospital. You can see the setup is exactly as I've shown in the other videos. We have the patient sitting up. We're using high flow nasal oxygen. We're sedating the patient. I have the monitors all in front of me so I can see everything all in one go. My assistant is standing on the opposite side. I start off by topicalizing the oropharynx and then the nasopharynx, and I giving the patient high flow nasal oxygen. I'm facing the patient. I'm able to communicate with the patient and make sure I'm not over sedating the patient. I suction before I start scoping, and you can see it's taken me 4 minutes to prepare the patient, and then only takes me a minute to actually do the scoping and intubate the patient. And this is what we do all the time. I'm showing you a quick one, obviously, but actually, even if it takes 5, 10, 15 minutes, it doesn't matter. Time shouldn't be a factor as to why you're doing an awake intubation. It should only be down to safety, and you take as long as it takes, making sure you do it the right way and the safe way. And if you do the same thing over and over and over again, you get very good at it. Your team understands what you're doing, and it becomes much more routine, and you're much less likely to avoid it when it is actually indicated. One of the things I wanted to talk about was how you do awake intubations when you use a video laryngoscope. So often when we think about awake intubations, we think about doing it with a flexible bronchoscope, like I've shown you already. But actually, you also need to know how to do it with a video laryngoscope. And there's some reasons for that. We did again another study where we did a network meta-analysis, and we looked at comparing doing video laryngoscopy awake versus flexible bronchoscopy. And actually what we found was that there's no real difference. You're as likely and as good at succeeding using a video laryngoscope than you are with a flexible bronchoscope. We just tend to do more awake intubations with a flexible bronchoscope because that's what we've always done. But actually you have good options, and it's a good alternative to doing an awake intubation, and it has some advantages over a flexible bronchoscope. You have different types. You have channeled and unchanneled awake video laryngoscopes, and I'll just give you some examples here. This is the patient who's again sitting up, oxygenated, topicalized, like we would do a normal awake intubation. It's slightly sedated, and we're using an air track here, which is a channeled video laryngoscope. This is my airway fellow who's never done one before, but we talked about it, and I talked him through it. And you can see the vallecular was there, and there's the glottic opening. And because it's channeled, once you've got a good view, you just gently advance the tube, and the channel of the video laryngoscope will direct the tube through the cords. And you can see the patient's tolerated this really well, largely because the patient is well prepared for the awake intubation, but actually it's a nice technique as well. And there's hardly any coughing there at all, and the patient tolerates the tube well. Now it's safe to do the check for capnography and then put the patient to sleep. This is another example using an unchanneled. This is a hyperangulated video laryngoscope. It is a gliderscope, and you can see again, I'm sitting in front, I'm facing the patient, so we're using it back to front. And this actually was a COVID patient, which is why we were all wearing PPE at the time. Because it's an unchanneled, it's a hyperangulated video laryngoscope, we need to use a stylet in the tube. You can see the stylet allows me to, guides me to the glottic opening, and then I advance the tube through the cords, remove the stylet, and then once I've checked for capnography, I will then induce anesthesia and put the patient to sleep. And again, you can see it's safe, it's tolerated quite well by the patient, and it's a nice way to intubate the patient. If you're good and you have this device, this is called a ProView, and it's an optical stylet which is within the tube. It's got a little camera on the end, and it allows you to flex the tip. And what we've started to do now is use this as the awake technique. So it's called an optical stylet, the ProView, and you can see the patient again is sitting up, is slightly sedated, is well topicalized, has oxygen, high flow nasal oxygen running. And I'm just going to, I've already prepared the patient. You can see I'm going along in the midline with my optical stylet, and I'm rotating the little rotator that it has on the end of it, which allows to flex the tube. And you can see there's the epiglottis there, and I'll just flex below the epiglottis, and you can see the arytenoids and the glottic opening and the vocal cords. And then we will advance the tube through the cords and into the trachea. And then we've done again another safe awake intubation in the patient with a known difficult airway using an awake technique. So it doesn't have to be a flexible bronchoscope. It can be an optical stylet. It could be channeled or an unchanneled video laryngoscope. All of these devices you have available to you, and you can consider using them awake if you are familiar with how to use them. But, and I've said this before, not everything is 100% successful. We have an algorithm which also developed for failure of awake intubations, because things always do fail, and you must always plan for failure. And the beauty of doing an awake intubation is that if you fail, if you're unable to succeed, if you're struggling to intubate the patient should still be breathing and should still be relatively awake. So you can always postpone, you can stop. And that's why you're doing an awake technique, because you know that you can bail yourself out of trouble. If you're in trouble, you can just say, you know what, we're going to stop now, and we're going to reassess the situation, call for help, postpone the operation. However, there are some situations where you can't stop, and you have to carry on, and you have to anesthetize the patient because the patient needs an emergency surgery or needs to go to critical care, in which case you have two options. One option will be you do an awake emergency front of neck airway with your surgeon, either through a tracheostomy under local anesthetic or a cricothyroidotomy, which you can do yourself. Or you do a high-risk GA intubation where you put the patient to sleep and then you intubate the patient with a video laryngoscope. Now that is a bit more risky, but when you look at the literature, that's often what happened. When the patient was thought to be difficult and awake intubation was attempted and it failed, we put the patient to sleep and they were able to intubate the patient to sleep. But they only did that because they couldn't intubate the patient awake. So plan for failure, which invariably should be postpone the procedure, but if not, then you may need to consider doing a high-risk GA intubation, sleep intubation, or an awake front of neck access airway, whichever one you choose. Now, I've been involved in as you heard in my introduction earlier, that I've been involved in writing a number of guidelines. I was involved in the 2015 guidelines. I was also involved, which is the intubation guidelines. And I was also involved in the awake track intubation guidelines. And these are the algorithms that we've put together for failure. Now, I would much rather follow the ATI guidelines for failure in a patient with a difficult airway who I'm struggling with than the sleep intubation guidelines failure, which is a bit more complicated and has many more steps involved. And what I'm trying to say here is, if the patient is thought to be difficult and you're running into trouble, you would much rather use the algorithm on the left-hand side of the screen than on the right-hand side of the screen, because you're in much more control in the first algorithm. And that's why you should consider doing these patients awake when you think they're going to be difficult. I'm going to just talk very briefly also about awake track intubations in COVID patients, because this is something that that we faced during the pandemic, and hopefully none of you will face again. But there's some considerations that I wanted to share with you. The first thing was we probably did the first ever awake intubation in a patient with COVID-19 who had critical airway obstruction and needed an intubation, not because, well, partly because the patient had COVID, but also because they had a large laryngeal cancer. And this is the first time we'd ever done one, and this is during the first surge. So we didn't know just you know, how scary this was, or how risky this was for the healthcare workers as well as for the patients. And so we were our papa hoods, and we did this in theatre. And I just want to share, first of all, this is the actual case that we did, and you can see that we did a nasal awake intubation. There's the soft palate, there's the uvula, and the uvula directs you. And you can see there's a whole load of tumor, a huge tumor in the supraglottic area. The whole upper airway is covered in tumor, and just at the top of the screen you'll be able to see some little hole there where the vocal cord should be, and we managed to get the scope around the tumor and into the glottis, and then railroad the tube in. But you can see the anatomy is distorted. All of this white stuff is probably COVID virus all over the patient, and it was very, very scary time. And we didn't quite know what adaptations we needed to do in these patients. But what we decided to do was to share some of our experiences, and one of the things that we noticed was that you use a remifentanil because it helps reduce the coughing, and obviously wants to avoid aerosol generating procedures, AGPs, and that's why remifentanil is probably a better choice for sedation. Start the sedation early so the patient is nice and relaxed. You may need to give a bit more because you want them to really, you know, try and avoid the coughing as much as possible. Don't over sedate, so be very careful with that as well. Make sure you monitor end-tidal carbon dioxide levels, and probably the trickiest part of this was the communication. It is very difficult to communicate with the patient effectively when you're wearing the hoods, when you're wearing masks, when the patient is probably wearing a mask as well, and the patient is nervous and is stressed and is trying to breathe and is struggling to breathe. It just makes that communication a lot more difficult. So it's really important to consider that and try and overcome that, and have a quiet room, and maybe prepare the patient as much as possible beforehand. But doing an awake intubation in these type of patients is a lot more challenging. So I think we're still, we've got a few minutes to go, so I'm still within time. So Ricardo, I'm sure will be happy about that. So just in summary, just to summarize some of the things that I've been talking about. So the first question I asked was why do we do awake tracheal intubations when we have video laryngoscopes? And in answer to that question, I just shared some of the data with you. The data of failure when you put the patient to sleep using a direct laryngoscope, which is about 5.5%. Failure when the patient has a video laryngoscope, which is about 2.5%, and failure for awake intubations, which ranges from between 1% and 2%. And even when you fail with an awake technique, what you find is that the outcomes are not as bad in patients with predicted difficult airways than if the patient is asleep and you fail. The outcomes tend to be a lot worse in the same group of patients. And for this reason, our number one recommendation in the paper is awake tracheal intubation must be considered in the presence of predictors of difficult airway management. So if there's anything that makes you think this airway may be difficult, then you should consider an awake intubation technique. Doesn't mean you have to do one, but consider one. Even if you don't do an awake intubation technique and you think there may be some predictors of difficulty, please plan better. Please plan for failure. Please have your plan A, B, C, D thought about, discussed, have the equipment for this, have all your colleagues involved, and make sure everybody knows that this may be difficult. And if it is difficult, this is what I'm going to do if my plan A fails. And just to end, I'd like to thank the 10 members of the ATI group. We met very regularly. In those days, it wasn't like it is now. We didn't know about Zoom and Teams meetings. We all met in person on a regular basis and worked very, very hard to come up with these guidelines. They've done very well. They've had over 200 citations already. and altmetric score of over 500. So it's done very well. Obviously, number of awake intubations dropped during the pandemic. It is starting to pick up again now. And my request is that consider doing awake intubation. Make sure you know how to do awake intubation. So when you need to do one, you are familiar with doing one, and you don't avoid it because you're scared about doing it, or you think, oh no, I don't know how to do this. Call a friend, call a colleague, ask for help, postpone the procedure. But if an awake technique is the preferred choice, or is the appropriate choice, then please try not to avoid it if you can. As I promised, this is the QR code for the Difficult Airway Society ATI paper that we published, the guidelines. It's open access, it's free. It has everything I've talked about already in there, and you can read it in your own time. And actually, we have a Spanish version as well, which I can't remember how you can access it, but there is a Spanish version that is available. If you want that, then please let Ricardo know. Then I will try and get the link for that as well. And with that, I will end my talk. And thank you very much. And I'm very happy to take any questions that you may have. Thank you.
Muchas gracias, profesor Ahmad, por su extraordinaria conferencia. Creo que ha sido para nosotros el poder escuchar de primera mano, de primera voz, las recomendaciones y las consideraciones que el grupo de la DAS está haciendo para mejorar la seguridad del manejo de la vía aérea de nuestros pacientes a través de la técnica de la intubación vigil. Quiero en este momento transmitir una pregunta que está en el chat y que es, espérenme un segundo. El doctor Walter Paredes nos pregunta si es válido aún el bloqueo a nivel de los cuernos mayores del hueso hyoides y el bloqueo transtraqueal.
So can you just repeat the question again?
Is it valid the blockade of the hyoid and transtracheal?
Oh, yes. Okay, sorry, I understand now. So you're referring to a topicalization of the airway using a block. So either you can do a transtracheal through the cricothyroid membrane, or you can even do nerve blocks using either landmark technique or ultrasound technique of the glossopharyngeal nerves and the other regional nerves. So we recommended using spray, topicalization. And the reason for that is because we wanted to make it very accessible and very easy and very straightforward. Because people don't do awake intubations very often, and if you recommended a technique where you had to use ultrasound or go through someone's neck, it gives another reason to avoid doing the technique. So just spraying the mouth and spraying the nose is very easy to do, and that's why we opted for a topicalization technique. However, using a transtracheal technique is very good. It still works, and if that's what you do, then please continue to do that. If you're going to use a regional technique, then again, if you do it regularly, then we don't say don't do it. However, the complication rate is slightly higher because the intravascular, intraarterial injection does happen, whereas with topicalization, it's a lot less likely to have complications. So that's why we recommend topicalization technique. However, you can use that technique if you are familiar with it.
Perfecto, gracias, doctor Ahmad. El profesor Robert Greif de Suiza está acompañándonos en esta oportunidad y me dice que tiene 3 preguntas. Adelante, Tino.
Hi, Ricardo. Hi, Imran.
Hi, Tino.
Mi primera pregunta tal vez es algo I think I'm changing to English. You called your guidelines awake intubation, but then you explain quite extensively the sedation procedure. So there are a lot of, I would call them hardliners. They say awake is awake, no sedation. Sedation is like prohibited. What's the point of view? Why is it still called awake intubation if you're doing some sedation? This is maybe it's a semantic, but for a lot of people, this they don't they have troubles to understand this, to say it very openly. So this would be my first question.
Okay, that's a great question. And we had lots and lots of discussion about this when we were writing the guidelines, because you're absolutely right. Awake means awake and asleep means asleep, but sedation is in the middle. Now, what we decided was to highlight that sedation can be given, doesn't have to be given, but it can be given, and usually it's given for anxiolysis, because patients may be stressed and anxious, and it can be given for amnesia, which again helps, because patients who come for recurrent airway procedures often don't like what they're experiencing, and amnesia does help with those patients as well. So what we stress is that if you are going to give sedation, you're only going to give a small amount. You're only going to give it usually for anxiolysis or for amnesia, and you're certainly not going to give too much sedation, because that can run into complications and is not a substitute for poor topicalization. And you're absolutely right. You can do an awake intubation on a patient purely on just topicalization, on local anesthetic. And often we do that. But I think it's just nicer for the patient if they have some anxiolysis and some amnesia on board, especially if they're having recurrent intubations. So I completely agree with you. And we spent hours and hours arguing about this exact thing.
Well, thanks. The next question is, you showed the use of high flow nasal oxygen, which I like a lot, but how are you managing this? Because they have two nostrils. So in which nose are you going with your fiber optic, or how do you manage these nasal prongs and having to introduce something else?
Yeah, I get asked that question a lot as well. And if you watch the videos, basically the nasal prongs are very flexible and very soft. So what I say to anybody who's working with me and anybody who asks me this question, I say just ignore the prongs, because the prongs they come in different sizes as well, but the prongs are soft, they're very flexible. Your scope can go past the prongs and your tube will go past the prongs, so you don't even need to remove them. And in fact, the prongs help for two reasons. One is when you start scoping, it actually guides you to where you need to go initially. And secondly, when you topicalize the nasopharynx, the high flow helps distribute the local anesthetic. And I found that actually when I topicalize the nasopharynx, the patient, you spray some local anesthetic in the nose and they cough, and it coughs because the local anesthetic gets aerosol straight down to the trachea or to the vocal cords. So keep the high flow nasal oxygen on, don't stop it, and just ignore the prongs, because the scope and the tube will go past the prongs without any problems. Trust me, I've done it many times. It definitely works. Thanks.
This is in accordance to my experience. My last question, maybe this is strange from Switzerland, but as this webinar is seen in entire Latin America, what you are presenting a lot of rather expensive, to say it in this way, material. What do you propose for low resource settings? They might not have video laryngoscopes, they might not have a fiber optic. So what would your recommendation for low resource setting doing awake intubation?
Yeah, again, another great question. I would say that the giving oxygen is probably not is available to most. Local anesthetics or topicalization would be available, and once you have a well oxygenated and a well topicalized patient, you can even use a direct laryngoscope if you gently place it and the patient is well enough prepared. An air track, the one I showed, the channel video laryngoscope, these are single-use, disposable, not very expensive as well. So there are options. If you have one thing that I didn't really talk about much is about the preparation and interaction with the patient. So if you explain to the patient, look, I'm going to topicalize your airway. I'm going to have a look with a gentle, place an instrument gently and have a look. And they accept this and they're aware of it, then they're more likely to tolerate it as well. So I would say very detailed preparation with the patient, explain to the patient. So even if you don't have the expensive devices available to you, even using a direct laryngoscope gently or using a channel laryngoscope gently will suffice.
Thanks a lot. Muchísimas gracias.
Fantástico, gracias Imran, gracias Tino, excelentes preguntas. Tino me robó la pregunta, la última, porque siendo yo latinoamericano era lógico que le preguntara a Imran acerca de qué hacemos nosotros acá en Latinoamérica. Y efectivamente, claro, tenemos recursos, una laringoscopía o intubación vigil no necesariamente requiere dispositivos sofisticados como los que mostró Imran, sino que es más bien una técnica y un experto que tenga la confianza y la experiencia con esa técnica y que ahí puede estar alguna de las claves, y esa es la pregunta mía, es una de las claves para mejorar la confianza en la intubación vigil. ¿Qué te parece? ¿Qué otra cosa necesitaríamos para mejorar nuestra confianza en esta técnica de intubación vigil? Porque ya ves que la respuesta es 50% que tienen confianza o algún 50% de los colegas han evitado hacer una intubación vigil cuando estaba indicado. ¿Qué otros elementos necesitaríamos fuera del entrenamiento o el tener un esquema como los que tú has entregado?
Yeah, I think, and it's the same in the UK and probably in Europe as well, is the opportunities. If you go to centres where they do many awake intubations, it's only, again, as I said, about 1% of the intubations that are done awake. So the numbers are quite small. So the question is how do you, first of all, gain competence and learn how to do them, but then how do you maintain it? You may learn how to awake intubation, but not do one for 2 or 3 years. So what I often suggest is that you look at different aspects of airway of an awake intubation and train and practice those, because those things you can practice. So get good at sedation, for example, on sedation lists. Get good at using a flexible bronchoscope. So use the opportunities. Anybody who's having a nasal tube, do a nasal intubation with a flexible bronchoscope if you have that available to you. So you're practicing your scoping technique. If you have access to an ORSIM or a bronchoscope simulator, practice your bronchoscopy techniques. If you have an ENT department in your hospital, then go to the ENT clinic and do some nasal endoscopies. They do nasal endoscopies on every patient that they assess, and it's a good way of practicing that technique in an awake patient. The other thing that I often recommend is doing a sleep video laryngoscopies as if you're doing them awake. So you saw in my videos, I had the patient sitting up and I was facing the patient. So often what I do with my trainees is I say, look, why don't you sit the patient up 45 degrees, we'll induce anesthesia, and we can practice intubating from in front. And what you're doing there is you're replicating an awake patient, but patient is asleep, and you're learning which hand to use, channeled, unchanneled. You're just learning the technique in an asleep patient from in front. So one day when you do it in an awake patient, all those things are more familiar to you. And as with everything, the more you do, the more familiar you are with it, and the better you do it, and the more confident you are at doing it. If you ask me to do awake surgery on a patient who needs an ankle operation just under an ankle block, I would be very nervous about doing that. I would avoid it because I don't do ankle blocks very often, and I wouldn't have the confidence that my block would be sufficient enough to do surgery on. And it's the same thing with awake intubations. If you are not confident doing an awake intubation and you don't ask for help, then you're going to avoid it. And this is the point I'm trying to make is that when it's indicated, then maybe you should do an awake intubation. And if you're not familiar with doing it and you don't do it very often, then first of all, do it more often so you get better at it when the opportunity arises, but also ask for help, but don't avoid doing it when it probably should be done, because that's when you run into trouble. And that's what the data has shown us.
Muchas gracias. Te cuento, Imran, que nos están viendo desde muchas partes de Latinoamérica, desde México, desde Bolivia, desde Argentina, desde Perú, y nos envían saludos afectuosos y hacen comentarios acerca de lo excelente de tu conferencia. También nos preguntan cosas, por ejemplo, el doctor Jaime Guevara de Perú, un gran profesor en Perú, que si es mejor la técnica spray as you go sobre el bloqueo de nervios.
Mhm.
So I was trained on the spray as you go technique. Again, it does involve you using often an epidural catheter and cutting the end off and placing the scope above the vocal cords and then spraying the local anesthetic on the vocal cords. That often makes the patient cough, and you can often lose the view that you had. So we decided not to make that as one of our recommendations. But if that's what you do, then it's a great technique, actually, if you do it properly. And this is what I trained on when I was in Oxford, but now I've moved to using just a topicalization technique, because with the high flow nasal oxygen, as I explained earlier when Tina asked me the question, it topicalizes the airway because of the high flow, and it aerosols the local anesthetic all the way down to the trachea. The other trick to do is if you ask the patient to take a deep breath in as you're spraying the local anesthetic, it often sucks it into the airway as well. But spray as you go technique is a well-recognized technique, well publicized, well published on as well, and it does work. My only problem is with it is that often you get this lovely view of the cords, you spray the cords with local anesthetic, and then they cough, and then you lose it, or you get some secretions on the end of the scope. And that's why I don't use it personally. But if it works for you and you do use it, then it's a good technique.
Muchas gracias, Imran. Como te decía, nos están viendo prácticamente de toda Latinoamérica, incluyendo Brasil también. El doctor Raúl Silva, también él está muy impresionado por tu conferencia, te felicita. También desde México, el doctor Juan Carlos Mandujano dice que desde hace años han estado recomendando la intubación vigil con distintos dispositivos, desde el uso del videoendoscopio, fibroscopio e intubación retrógrada. Y aquí también el doctor Guevara, que ya nos hizo una pregunta, y el doctor Bocanegra mencionan la intubación retrógrada despierto, que podría ser una buena alternativa para solucionar casos de vía aérea difícil en lugares sin dispositivos ópticos, como en nuestros hospitales, pero también en pacientes en que la visualización, la visibilidad de las estructuras laringeas esté alterada, por ejemplo, en un trauma maxilofacial. ¿Qué te parece esa técnica de la intubación retrógrada, Imran, como técnica de intubación vigil?
I've only ever done it once, and it was on my first day in my airway fellowship, and it was a scary time. It is a recognized technique, and as you said, in patients who are bleeding or have had a maxillofacial trauma, and there's the anatomy is distorted. If you use a flexible bronchoscope, the blood absorbs all the lights. You can't really see much very well. So yes, in certain situations, I think it will have advantages. But again, it's a complicated technique, and you need to know the steps, and you need to know practice how to do this and which equipment to use. So often you can use the guide wire from a nasogastric tube, or the guide wire from a urology catheter sets, or urostomy sets. But you need to know what to use, and you need to know how to use it. You need to know that when you puncture the crocodile membrane and you feed the wire up, that you want it to come out of the mouth. You then want to railroad the tube over, but you have to remember that when you get to the front of the trachea, you have to remove the wire, otherwise the tube won't advance any further. So it's a technique that needs practice, it needs understanding, and my question back is would you do an unfamiliar technique in a patient who has a very complicated airway, which is a retrograde technique, because we don't do this very often. If you do it a lot and you're familiar with it, then I think it's fine. But if it's something that you haven't done before, or you've only read about, or you've only seen many years ago, this is probably not the time to do it in a patient who has maxillofacial trauma. So yes, recognized technique, good technique if you know how to use it. But as I said, I've not done this I've done it once in my career, because I've avoided it, because I think it's a bit complicated, and you need to understand and know the technique well.
Muchas gracias, Imran. Quisiera ahora, a continuación, formular las dos preguntas que nos quedan para que Gabriela nos pueda mostrar. Y ahí tenemos la tercera pregunta para después de la charla. ¿Cree que ahora, después de esta charla, consideraría hacer una intubación vigil estando indicado? ¿Están respondiendo?
This will tell me whether my talk has been worthwhile or not.
¿Están respondiendo? ¡Wow! Es unánime, parece. Bueno, casi el 60% de los participantes están respondiendo. Ha terminado. Compartimos los resultados. ¿Qué te parece?
This is great. So this is, I'm very happy to see this, because this is the whole reason why I wrote or wanted to write the guidelines, and why I want to educate people and encourage people to do more awake intubations. Doesn't mean you have to do it, but be confident at doing it, and please consider it. So I'm very, very happy to see that that shift from 50% up to 98%. It's fantastic.
Creo que justamente uno de los objetivos que tiene este webinario es el de cambiar un poco y mejorar nuestra percepción acerca de algunas técnicas y algunas consideraciones en manejo de la vía aérea. Vamos a la cuarta. ¿Ha hecho alguna vez una intubación vigil usando un videolaringoscopio? Un videolaringoscopio. No un fibroscopio o un microscopio flexible, sino que un videolaringoscopio. ¿Ha hecho alguna vez una intubación vigil usando estos dispositivos? Vigil. Probablemente muchos de nosotros hacemos intubaciones con videolaringoscopio, pero en pacientes dormidos. Pero vigil no es tan frecuente. Y aquí tenemos más del 60% está respondiendo ya. Creo que estamos listos. Finalizamos la votación, compartimos los resultados. Vigil, la mayoría, un tercio, 2/3 no lo han hecho prácticamente. Intubación vigil usando un videolaringoscopio. ¿Qué te parece?
Yeah, in fact, 40% have done it, which for me is encouraging. Again, it's a newer technique. It's something that I think is starting to get more and more popular. And I think as we become more familiar with videolaryngoscopes, with time, I think that number will change. We'll be doing more awake videolaryngoscopy intubations, as opposed to just using a flexible bronchoscope. I still think the flexible bronchoscope has an advantage over the videolaryngoscope, but I think the videolaryngoscope is almost as good as in most situations than a flexible bronchoscope. And if it means that you do more of them and you're more likely to an awake intubation using a videolaryngoscope, then that's fine. I'm happy with that.
Fantástico. Bueno, yo creo que ha sido un webinario extraordinario. Creo que el doctor Imran Ahmad nos ha proporcionado muchas claves para mejorar nuestra práctica en la intubación vigil, que es una estrategia muy importante en el manejo de la vía aérea difícil anticipada. Y creo que cada uno de nosotros se va en este momento con nuevos elementos que nos van a servir en nuestra práctica habitual para mejorar nuestro quehacer con nuestros pacientes. El doctor Guevara nos dice, el doctor Ahmad ha hecho un excelente trabajo es responsabilidad de nosotros ahora poner en práctica la técnica y divulgarla. Bueno, ese es uno de los objetivos que tiene nuestro webinario, es el de divulgar el conocimiento y las buenas prácticas en anestesiología para mejorar nuestra seguridad en la atención de nuestros pacientes. Quiero finalizar con, si quiere, el doctor Ricardo Latrop, decir algunas palabras de agradecimiento en nombre de la universidad, doctor Ahmad.
Por supuesto, doctor Ahmad, muchísimas gracias. La verdad es que en nombre de nuestro equipo de anestesiología de la universidad, pero también en nombre de la dirección de posgrado y del decanato de nuestra facultad de medicina, la verdad es que muchísimas gracias por esta conferencia tremendamente interesante, muy generadora de conocimiento, videos excelentes. La verdad es que ha sido un agrado y una sensación, a pesar de la edad que tiene uno, de seguir aprendiendo. Y esto ha sido muy valioso, el agradecimiento de la universidad, de nuestro equipo de anestesiología, por lo tanto ha sido un agrado escucharlo, y por otro lado agradecer toda su entrega y con el objeto de aumentar los conocimientos de los anestesiólogos, no solo en su país, sino que también en Latinoamérica, que para nosotros es tremendamente importante la formación, de ir creando situaciones de mayor cantidad de formación. En ese sentido, muchísimas gracias en nombre de la universidad y en nombre nuestro, y que por supuesto esperemos contar con usted muchas veces en todos estos procesos de educación continua y evidentemente de intercambio de conocimiento. América Latina tiene un problema de recursos, eso es cierto, pero esto nos incentiva a buscar los recursos, nos incentiva de alguna manera a intentar situaciones en indicaciones médicas, el tener acceso a conferencias como la suya. Por lo tanto, muchísimas gracias en nombre de la universidad y de nuestro equipo de anestesiólogos del programa de anestesia de la Universidad Diego Portales. Un agrado, doctor.
Thank you so much. Very kind words. I don't think I deserve all of them, but it's a real pleasure. As I said, I've got this. I think I've got a soft spot for the Latin American airway community. I think you guys do some amazing work. Your education program is fantastic, and as you said, we're always learning. I'm always learning. I'm still learning. So it's great to share the knowledge and keep learning and keep getting better. So thank you so much for inviting me and having me.
Muchas gracias, Imran. Ha sido realmente un privilegio haberte estado contigo, haber contado con esta extraordinaria charla, que hay muchos comentarios en el chat de diferentes partes de Latinoamérica. Hay uno que se agregó de Ecuador y que nos están diciendo que están felices con tu conferencia y que ha sido extraordinariamente útil para todos nosotros. Quiero finalizar compartiendo mi pantalla. Para mostrarles, bueno, esta cosa a mí esto me enorgullece a mí, porque esto el año 2021, cuando partimos, nos veían de muchas partes de Latinoamérica, algunas partes de España, etcétera, algunos latinos de Estados Unidos. Pero desde el año 2022, el año pasado, hemos tenido un aumento notable de auditores, de participantes de muchas partes, más partes del mundo. Nosotros estamos también transmitiendo nuestro mensaje a través de las redes sociales. Hoy día tenemos más de 600 en Facebook, en nuestra página de Facebook del programa Anestesiología. También tenemos este canal de YouTube de anestesia, donde ustedes pueden ver todos los webinarios. Próximamente este webinario va a ser subido al canal, por lo tanto quienes no han podido acceder hoy día a verlo, van a poder hacerlo a través del canal de YouTube de Anestesia UDP, y ustedes pueden activar este código QR que ustedes están viendo para poder acceder al canal. También en Instagram y en Twitter también publicamos nuestros avisos para asistencia a nuestros webinarios. Quiero anunciarles finalmente que el próximo sábado 25 de marzo vamos a tener un nuevo webinario a cargo del doctor Daniel Perín de Brasil, quien nos va a hablar acerca del manejo del paciente con tumor cervical. Esto es muy interesante. Él tiene una gran experiencia, tiene un grupo muy dedicado a la docencia en Brasil, y creo que va a ser tremendamente interesante, y los dejamos a todos desde ya invitados a unirse. Estén atentos a nuestros canales de redes sociales para que puedan obtener el enlace de Zoom y se puedan conectar. Recuerden que contamos con traducción simultánea al español, al inglés y al portugués, por lo tanto van a poder entender perfectamente lo que el doctor Perín nos va a hablar. Desde ya los esperamos. Agradecemos a nuestro equipo de traducciones remotas. Agradecemos también a Gabriela Ramírez, quien es nuestra webmaster, que ella es el pilar de todo lo que hemos estado haciendo hoy día. Así que muchas gracias a Traducciones Remotas, muchas gracias a Gabriela, y nos vemos en el próximo webinario. Que tengan buen fin de semana.
Muchas gracias, Ricardo.
Un abrazo.
Thank you.